Thanks for joining us,
Perfect.
everyone.
I'm back, guys, this time for a full hour. So bear with me as we go through things. Planning to spend about half an hour talking about GI targeted agents. Of course, we'll talk about the Liz pearls if you encounter these drugs that you'll see in practice. And then we switch over to immune checkpoint inhibitors for the second half, really focusing on toxicity management. But yeah, let's get started. Same objectives as last week. We're just shifting gears in terms of what drugs we're covering. Let's start off with panitumumab and cetuximab. Listed here on the slide is how these drugs work. They target that EGFR receptor on the outside of the cells. And when that happens, you get the shutoff of dimerization of the different receptors, and then the signal transduction cannot occur downstream. In terms of how they're dosed, roughly we use these every 2 weeks when in combination with different GI regimens. Biggest toxicities from these, they do have a risk of infusion-related reactions, a little bit more so Cetux versus Pani. They do cause EGFR acneiform rash. We'll talk about that. They are also culprits of wasting magnesium. So thankfully with our resident Project Molly last year, we are able to run magnesium faster now, but just know that these drugs will waste magnesium for patients. We'll talk about patient education coming up, but big picture, they need to be educated about this acneiform rash because it looks like acne, but it is not acne and it is not treated like acne. So here's a picture of what it looks like. As you can see, there's those little pustules, most common places that it occurs, the face, the chest, and the upper back. Not saying I have seen it anywhere on any body part, to be honest, especially areas that might be more exposed to sunlight. We know UV radiation can trigger it. It's going to affect the bulk of patients. So 75 to 90% of patients, and it does sometimes have an early onset. So within those first 2 weeks of therapy, not saying that this is something that I think patients hear that and they think, oh, it's going to happen once. But for these patients that are on these drugs for continuous, it's something that can wax and wane over time. It gets better, and then all of a sudden they can have a flare up. Additionally, these drugs cause unique side effects. Look at this hair growth. So people's eyelashes will continue to grow. It's almost like the hair becomes more wiry, more coarse. You will notice in patients that might have received Pani or Cetux for many, many months, their hair will look like that, more coarse and wiry. In addition, it causes this nail toxicity. As you can see, it looks, especially on this bottom left picture, extremely painful. It's like these like fissures. It's almost like if you cut your cuticles and you get an infection, it looks just like that. And then, of course, the Pani rash picture here on the bottom right. Now, since I love supportive care articles, how do we know, or research, how do we know in terms of doing the therapies with hydrocortisone and doxycycline? Why does this work? So this STEP trial actually examined a preemptive approach, so trying to prevent this versus being a reactive approach to managing it, so managing it after it occurs. So in that preemptive approach, and what is built in our treatment plans for these patients, you will notice an over-the-counter prescription for hydrocortisone cream, 1%, applying at bedtime, and then oral doxycycline. So yes, an antibiotic, we're using it for its anti-inflammatory effects. The incidence of grade 2 or worse acneiform rash was 29% versus 62% in the reactive group. In addition, they did have a better quality of life. So it's really important to note that. I know doxycycline for some people is not the best tolerated, especially it can cause a lot of GI distress. But just know, even if they can get some sort of if they can get some drug in, it will help them. So know that it's built in those beacon plans for our patients. Additionally, we have a health facts for you on this one. It's about a 3-page handout for patients that you can give them. It contains a lot of great information for things that they can do at home. Awesome. Shifting into capecitabine, an oldie but a goodie. So capecitabine is an oral prodrug, which when it is converted or taken in by the GI tract, it goes to the liver and then to the tumor cell where it's converted into 5-FU, which is the IV formulation. It works the same way. I think here a lot of times folks don't, in this bottom left corner, do not always understand the metabolism of this drug. So when you see this DPD, this is how the drug is actually 80% of it goes through this route, which is eliminated from the body. Active drug is only about 1 to 5%, but we only need that 1 to 5% to be active in terms of it being efficacious. But this DPD takes care of about 80% of the drug elimination. Now, DPD is definitely a hot topic in terms of if you get this ahead of time versus not, even for our 5FU patients. Right now, UW, we do not test to make sure that patients have intact enzymes versus if they're deficient. It's very hotly debated, guys. But just know if you do have extreme toxicities, test for this. We can do that. Biggest toxicities that you will see from capecitabine, hand-foot syndrome. We'll talk about management of that coming up. It can cause mouth sores, diarrhea, low risk of nausea, but it can happen. Some myelosuppression, although I would say not compared to other drugs. How it's applied, it comes as 2 different tablet strengths. It does interact with warfarin. Warfarin, try to convert them at best as possible. You can do it, but it's extremely cumbersome, and there's a lot of INR checks that need to be happening for patients if they are on warfarin. Patients need to be educated about moisturizing their hands and feet, especially when you have your older farmer guy from Wisconsin who looks at you like, I've never moisturized my hands or feet. Telling them where to go in Target or Walgreens to get moisturizers can be very fun. Making sure they know about antidiarrheals, because again, it has that diarrhea risk. And again, an as-needed nausea med are what patients need to have. So this hand-foot syndrome, I'm really going to focus on this. You can see it from capecitabine and continuous infusion 5FU, in addition to some other chemo agents. What it looks like, so on the palms of the hands and soles of the feet, it causes this dryness, cracking, and peeling. In more severe cases, it can cause burning, redness, and swelling. In really severe cases, blisters and ulcerations can happen. Again, because I love supportive care trials, some recent updates in what you should be telling your patients on capecitabine. So topical diclofenac, this was the DTORCH trial. They randomized breast and GI cancer patients to receive or do topical diclofenac versus placebo. They did have less incidence of hand-foot syndrome in that diclofenac group. And so with this, please use this, especially out of the gate. Go through with the patients to apply topical diclofenac, which is over the counter. They have creams or gels available. It doesn't really matter. I usually say get the cheapest. Apply that twice a day in addition to moisturizers twice a day because of that reduced incidence. In addition, now capecitabine, again, multiple different indications besides just GI, can be used with radiation, which is usually a 5.5-week course versus more cycle-based. So days 1 through 14 of a 21-day cycle. In some cases, days 1 through 21 of a 28-day cycle. But in a metastatic setting, we're becoming more aware that you can dose this in a different way to reduce toxicities, but still be efficacious. And this 7 on, 7 off was actually published. They took metastatic breast cancer patients. They did a fixed dose, so 1,500 milligrams twice a day, 7 on, 7 off, versus the FDA approved dosing, which is usually 1,000 to 1,250 milligrams per meter squared twice a day. There was no difference. The overall survival at 36 months, as you can see, was 21.2 months in fixed dose versus 19.6. There was no difference, and better quality of life and less toxicities in that fixed dose. So we've actually done this in our GI cancer patients, especially older patients. We've done a 7 on, 7 off approach. And I will say patients tolerate that better. And the goal is really to keep people on therapy and have a better quality of life. And so that really can be a benefit for some patients. We do have a health facts for you that you can print off and give patients. I will give this in addition to an oral chemotherapy handout for our patients on capecitabine, just because it does contain really good information for them when they're at home. Okay, moving on to bevacizumab, and then it's Me Too drug, ramucirumab. These drugs are really cool, and I pulled this from the drug website because I think it's a cool picture. They bind to a VEGF that's floating around, because the thought is if the tumor can't grow its blood supply, then it either stabilizes it or shrinks it, which is a novel mechanism of action. Bevacizumab has been on the market for a while, and just know it does have a variety of indications, not just GI. Ramucirumab, a little bit more niche. It's used, it doesn't have an approval in colorectal cancer. We don't use it in that setting. We are a Bev institution, but it's also approved for gastric cancer, HCC, and non-small cell lung cancer. So because it's interfering with the vasculature, this is where the toxicities come into play. Hypertension, it's usually not, you usually don't see patients get one Bev dose and it skyrockets. You usually will see their blood pressure just slowly increase over time. So each cycle, it just slowly increases. Most often, you can continue to treat patients with bevacizumab. You just need to control that hypertension, and that's where antihypertensives come into play. Again, this can have poor wound healing, needs to be held around different surgical procedures, and proteinuria. You'll see in our treatment plans, we have those labs built. Patient education, really monitoring for blood pressure, signs or symptoms of bleeds or clots, and then of course, notifying us if they have any surgical procedures. Now, ramucirumab appears to have a more increased risk of a reaction. So bevacizumab has an extremely low risk. RAM actually appears to have more of an increased risk, and patients actually get a pre-med with an H1 antagonist. So just know that's built in. Lonsurf, newer drug, has a niche indication more for a third line or plus setting for patients with colorectal cancer. Lonsurf is two drugs. It's trifluridine in combination with tipiracil. Trifluridine is the active component. As you can see here, it goes through phosphorylation and then inhibits DNA. Tipiracil actually inhibits thymidine phosphorylase, which is the enzyme that takes trifluridine and degrades it. So it actually keeps the active trifluridine in a more higher concentration. So just know that if you're educating patients and if you geek out with some patients, telling them that it reduces its degradation. So Lonsurf, unique dosing. So it's 35 milligrams per meter squared per dose, dosed twice daily. The package insert is for days 1 through 5 and 8 through 12 of a 28-day cycle. I'm going to be quite honest, most patients do not tolerate this, especially in the third plus line setting. We actually do days 1 through 5 and 15 through 19, which actually is very nice because you will sometimes see Lonsurf in combination with bevacizumab in a colorectal cancer setting, and that aligns with every bevacizumab dose. This alternate dosing leads to decreases in the incidence of neutropenia and anemia, which are one of the dose-limiting toxicities for this. So I highly encourage you to use the days 1 through 5 and 15 through 19. We actually, Dr. Deming and I did a study with Vanderbilt. We're going to be publishing our results soon that just shows patients tolerate this much better. In terms of what you're going to educate patients, of course, just because of the count suppression risk, infections, nausea and vomiting management, it is listed as a low risk, but quite frankly, most patients need to schedule anti-nausea meds before each Lonsurf dose. So it's something we usually come out of the gate and do. We'll schedule an ondansetron before each Lonsurf dose, making sure they know how to manage their diarrhea. And then, of course, adherence, giving them calendars if that's helpful, because this is a unique dosing structure. Okay, shifting into multi-kinase inhibitors. Globally, they target many different kinases on the outside of the cell. We will talk about what you're going to see as class effects. Multi-kinase inhibitors are used for a variety of different indications. I pulled the ones that are in the GI population to talk about, just to talk about some pearls that you'll see for the patients with GI cancers. The first, regorafenib. This is going to sound unprofessional, but I think because regorafenib hits so many different kinases on the outside of the cell, I think of rego as a dirty drug. It has a lot of toxicities and it is not very well tolerated. We do have this built. There's a note in the beacon plans for this drug to consider a ramp. It comes as 40 milligram tablets. The dose is 160 milligrams by mouth daily for days 1 through 21 of a 28-day cycle. Often what we will do is in that 3 weeks, we'll start with 80 milligrams for a week, then 120, then up to the target dose of 160. If you are very concerned about tolerability, doing 80 milligrams for the first cycle is completely valid, and your patients will tolerate it better. In terms of side effects, hand, foot, skin reaction, we'll talk about that coming up. Extreme fatigue, diarrhea, hypertension, and rash are all really, really big ones with this. Indicated for colorectal cancer, HCC, and GIST at this time. Very cool thing that we discovered because of that increases in blood pressure. There is actually an order in HealthLink to get patients to record their blood pressures through MyChart. If you type in MyChart, you'll see the options available, but that way it goes to the patient and they can record their blood pressures at home and it gets sent back to you. It's really cool. So just if you are concerned, especially starting one of these agents with patients and their blood pressures, they can send you them, which is nice because you get to review it every so often. Sorafenib, this is a continuously dosed drug, 400 milligrams by mouth twice a day. There is published to consider ramping this drug. I think it was a VA population. They pulled it starting at 200 milligrams twice a day, then ramping to 400, 200, and then 400 twice a day, just because of those side effects. So again, hypertension, diarrhea, hand, foot, skin reaction. As you can see, these multi-kinase inhibitors globally have the same side effects. Sometimes there's niches between, but if you look at all the different kinases that these affect, that is where all the side effects come into play. This one indicated for HCC and GIST. Now, I love this picture. This picture, let's talk about some skin toxicity. So starting with this far left photo of the foot, what is this and what drugs can cause this? Now, it might not be anything I talked about today, but rather something that you've heard in the past. Who has any ideas? So if you see this foot, what are you going to think?
Are you getting at hand, foot, skin syndrome here? So
not necessarily hand, foot. This is actually from taxanes. Taxanes can cause this oncholysis and these darkenings. There's like blood underneath the toenails. This is taxanes. This will get better. Sometimes it can be painful, sometimes not. I will say we have a very good oncodermatology program that if it is very painful for patients, they can go and see them and they'll sometimes have recommendations on what to do over time. What about the middle foot? It's dry, it's cracking, it's peeling. This is hand-foot syndrome. Yep. So you will see it from capecitabine, Doxil, 5-FU continuous infusion. You also can see it from anthracyclines. It's rare, but you can see it, and some antimetabolites too. And then finally, this last picture is the hand-foot skin reaction, which is distinct and different from hand-foot syndrome. This hand-foot skin reaction looks like blisters. It can be painful. It develops calluses, especially on the pressure points. But patients like this, usually this is extremely painful and they can't walk. I'm always more concerned with my patients who might have a diagnosis of diabetes, where they might not be able to feel their foot because of neuropathy, and these can develop. So in those patients, I say, make sure you're looking at your feet because these can develop overnight. So with this hand-foot skin reaction, what do I educate patients on? Very similar things in terms of moisturization. They can use pumice stones if they develop any sort of calluses that are just kind of, that thickened skin. Urea cream can be used twice daily on those calluses. using good moisturizers. If at any point it's peeling, they can't walk, then you're going to increase your management, most often holding drug, letting some things resolve, dose reductions, oral analgesics if it's extremely painful. Sometimes topical lidocaine can work for some people, but most often you need to be off that drug for a period of time to allow those tissues to heal. Okay, moving into pemigatinib and futibatinib, very fun names to say. Both of these are indicated, they're FGFR inhibitors. Looking here in the slide, it's very, very busy, but what it does, FGFR inhibitors bind to FGFR 1, 2, and 3, and therefore when they do this, it results in decreased FGFR related signaling. You have decreased then expression in the cell, and the cell can't live. Very similar mechanism, just targets a different kinase, which is FGFR. So we have PEMI and we have FUTI. PEMI is cycle-based, very unique dosing of 13.5 milligrams, days 1 through 14 of a 21-day cycle, with or without food. Again, you're looking for that FGFR2 genetic alteration for these patients. If they have it for cholangio, you can use these drugs. In terms of side effects, biggest ones that I've seen, fatigue, changes in electrolytes with both, especially the phosphorus, so make sure you're monitoring that. Diarrhea, nail changes. So this causes this unique nail toxicity. The nail will start to separate from the bed, and it'll actually become extremely thick. If that is happening to your patient and it's becoming extremely painful, you need to hold, dose reduce, and then at a certain point, I just get them into Oncoderm because they're going to need, because nails, again, they grow slowly, they're going to need some care over time. And so they're usually the best folks to be taking care of this. So PEMI, cycle-based. FUTI, it's continuous dosing, so it's 20 milligrams by mouth once a day. Again, same indication for that FGFR2 genetic alteration. Very similar side effect profiles, although some of those toxicities look a little bit different. Those electrolyte changes, nausea, sometimes changes in kidney or liver function. You might see some count issues, but usually that's not globally the side effects you're going to see from these. Oh, other thing I should say, eye exams need to happen with these drugs. Baseline ophtho eval, and then it's every 2 months for 6 months, and then every 3 months thereafter, because it can cause eye problems. So patients need to be notified of that ahead of the game. In terms of it being baseline, I'm usually okay with it if it's done within the first 1 or 2 weeks. And it's not a quick onset for those eye changes or eye problems, so just know that. But they need to have an ophthalmologist because that's who you're going to send them to if they start to have problems. Moving into a different class of drugs that we use for cholangio, ivosidenib. I thought this was a really cool picture because for cholangio, it shows the different targets that we have coming down the pipeline, some of them, versus how prevalent like an IDH1 mutation is. So patients, those FGFR alterations are 10 to 16%. So we do have targets for these patients. Ivosidenib is also approved for AML, but it is also approved for IDH1 mutated cholangiocarcinoma. How this drug works, it's a oral small molecule inhibitor of that IDH1 enzyme. So susceptible IDH1 mutations can lead to increased levels of 2-HG in cells. And in cholangio, how it works is it reduces those 2-HG levels in the cells. In general, and I won't speak for the AML population, but cholangiocarcinoma, my patients tend to tolerate this drug actually fairly well. You do have to monitor QTC. I have seen QTC prolongation with this drug. You know, you see it on so many drugs that you're not always sure, like, what's the incidence? Is this a big one? For this drug, it can happen. And there are specific instructions on what to do if you do have a prolonged QTC. Changes in electrolytes can happen. I think that's more related to AML patients. I mean, quite honest, I usually don't see them in mine unless they have a high tumor burden. Other things, diarrhea, some decrease in appetite can happen over time. But in general, for my patients, this is actually a fairly well-tolerated therapy. Okay, now talking, I'm kind of going off the cuff with this because it's exciting. It's a new drug. Zolbetuximab is a Claudin 18.2 inhibitor, which is unique for gastric cancer. So this Claudin 18.2 is expressed only on gastric mucosa, and it's retained in gastric cancer. And so I find this picture here, here's your stomach, with this Claudin and highlighting how zolbetuximab works. So this is actually a first-in-class chimeric immunoglobulin that's highly specific for this Claudin 18.2. It stimulates the immune effectors to induce ADCC and CDC. So again, because of this, your that cancer cell will die. Again, novel, first in class, really exciting. We don't have a lot for gastric cancer. We did have the study with Zolbe here, so we did get some experience with it. Now, very interestingly, just to talk about the FDA, it was denied, I believe, about a year ago. Not denied for efficacy, but it was denied because the FDA did not approve the plants that Zolbe was produced in, which I have never seen happen in any other drug that's been approved in my career. So kind of shocking. So the FDA gave them an action plan to improve all the things that were wrong with these plants. Anyways, it is pending approval in November of 2024. So I wanted to include it in this because you will see this quickly start to be used in our gastric population. It is dosed on day 1, followed by every 3 weeks after that in combination with chemo. That's how I think what they did to the FDA, but extrapolating to different doses for modified FOLFOX6, you might see that change to an every 2-week dosing because that chemo regimen is every 2 weeks. So we'll see what comes out. Here, the Spotlight and the Glow trials were the 2 different combinations, or the 2 different trials that were done for gastric cancer with FOLFOX and then in combination with KBOX. Very interestingly, nausea and vomiting, this drug has a high risk of nausea and vomiting, especially in the first 2 cycles. So you will see this built that way. In addition, it does have an infusion reaction risk. Other things that I kind of teased out, it does cause some count suppression, but that's in combination with chemo, so I'm not quite sure yet. We'll see what happens when the data comes out officially, when it gets approval. Biggest thing with this, though, that we found with the trials was the chemotherapy-induced nausea and vomiting, which was legit for some patients. So exciting news. Zolbe will probably be coming November of this year. Okay, I'm on time. Shifting into immune checkpoint inhibitors, I consider this the drug class of my time, where immune checkpoint inhibitors really have revolutionized the treatment of so many different cancers, beginning with melanoma. Now, I'm going to focus on immune checkpoint inhibitors, but I thought this was a very interesting graphic showing the FDA approval of different immunotherapies. So, right, like we've been figuring out since 1986, right, that we know the immune system is involved with cancer and how do we harness it or reduce it so that we're able to treat cancer better. We're going to focus on anti-CTLA-4, which was produced and on the market in 2011, anti-PD-1s 2014, anti-PD-L1s 2016, and then anti-LAG-3, which is kind of the newest one, that one coming out in 2022. As you can see, there's different things targeting cytokines, cancer vaccine, checkpoint inhibitors, which we're going to focus on, viruses, CAR T. It's a really exciting time to be in oncology. Of course, as you guys know, it's probably why you went into it. But we're only going to focus on checkpoint inhibitors because they're used in so many different settings. Graphically, what we're looking at, anti-PD-L1s hit the tumor cell, bind to PD-L1 that's on the tumor cell. PD-1 binds to PD-1 on the T cell. Dendritic cells are also involved in this picture. But again, we have all these different immune checkpoints that happen, tumor cells, cancer cells, or tumor cells and T cells, and what we can do about it. Now, I still love this picture. So this anti-LAG-3, what happens over time we've discovered is that our T cells actually get really tired. And why relatlimab came on the market was it was anti-LAG-3 inhibitor. And when it does that, it energizes the T cell again to be active. And so that combination right now is only approved for melanoma, but something where we've actually seen some good benefit in that. I love this website. We are not going to talk about immune checkpoint inhibitors and all the different indications. That's like a course series. That's like a full week. But this website is really cool, and I highlight this many years because it has the different drugs that are approved, the different immune checkpoint inhibitors that are approved. You can highlight the different settings that it's approved in. And when you hover over the little dots, it'll tell you what clinical trial got that approval for that indication, which I think sometimes you can get lost in the different checkpoints and keynotes and all those numbers. This will give you the pivotal clinical trials where they got those approvals, which is really cool. So just keep this as a reference. Again, so many different indications, so many different drugs, which I'm showcasing right here. So your CTLA-4 inhibitors, ipilimumab was the first guy in the market. We have the most experience with that. There's a variety of different ways that we dose it. We're discovering with CTLA-4s for some settings that lower dose with a bigger time gap, so an every 6-week regimen versus every 3-week, but more continuous, is actually better tolerated. You have less side effects. So just know that you will see that for some indications. And then tremelimumab was approved not that long ago, maybe 2 years now, in combination with durvalumab for HCC. It appears to be, and maybe this is just my HCC population, but I've had a lot of side effects from Tremi. So again, CTLA-4 having more side effect risk, almost ramping up the immune system more. We have seen a lot of side effects from that, especially in the Kratz clinic. PD-1 inhibitors, there are a lot of them, Pembro-Nivo being the first on the market, followed by cemiplimab and dostarlimab. New this year are the two other ones listed. I'm not going to speak to them. They're indicated in Merkel cell and I believe lung cancer. I am not sure. I would have to find out from my colleagues if we have these, but just know that they were just FDA approved this past year. PD-L1 inhibitors, atezolizumab, durvalumab, valuumab, and then LAG-3, relatlimab, only in combination with nivolumab. So monitoring, we have tried to standardize monitoring across UW for these immune checkpoint inhibitors in terms of how often we're getting things and why. I've taken a screenshot here of the NCCN guidelines for monitoring side effects. You will notice that we'll have your CBC, your CMP, your thyroid functions, your cortisol levels, things that have been removed in the past 5 years. We've removed amylase and lipase. It's not recommended to do routine monitoring, not unless there's symptoms. But this and these guidelines here will give you an idea of how often you should be testing, especially if you they aren't working at UW, how often to be testing, what to do when, and what to use for testing. So just know this exists in the NCCN guidelines. Now I've highlighted side effects briefly, and I kind of talked about, CTLA-4 having higher incidence of side effects. I think it's always important to know where we've come from and where side effects don't always necessarily correlate with responses. But let's talk about the history of melanoma treatment because I think this is really cool. So IL-2, which has a comeback for the melanoma population. We're going to be using it with some CAR T therapies. IL-2, old drug, it essentially throws gas on the immune system, and 85% of patients have grade 3 or worse toxicities. These patients for this regimen have to be admitted to an ICU. We do not do this at UW. I believe Freighter might still do it, but just know gas on the immune system, 85% of patients. Then IPI got approved, 26% of patients had grade 3 or worse toxicity. The PD-1 inhibitors got approved. They're better tolerated. They're more specific, 15% of patients. Then ipilimumab was combined with nivolumab, and about half of patients have a grade 3 toxicity. So again, if you're hitting two different checkpoints, just think of more side effect risk. Nivolumab, relatlimab, 40% of patients, so less than ipi-nivo, but just know that it is significantly more compared to PD-1 inhibitor by itself. Now, we do know combination will have potentially better outcomes, but sometimes that comes at risk of a higher incidence of toxicities. And that's something that you as providers would go through with those patients. I love this guy. So side effects, essentially any organ system can be affected by immune therapy, immune checkpoint inhibitors. And that's because when we're allowing the immune system to be more active, that comes into play potential side effects. Now, what I hear, globally, these therapies compared to, traditional cytotoxic chemo where patients, the nausea risk, hair loss, those sorts of side effects, we don't think of that with immune checkpoint inhibitors, but they still can cause very serious side effects. And it's not something to skim over with patients. Again, in general, yes, they're better tolerated for patients, but just know that there are serious risks. Timelines, I will go through patients with kind of timelines of when they can potentially expect side effects. So CTLA-4, I love this graphic still, even though it's old. Within 2 to 4 weeks, that's when the risk of rash happens, followed by diarrhea between weeks 4 to 6. Further down the road, that's when you can see the risks for hypophosphitis and liver toxicity. Again, your liver function tests and your cortisols and thyroid function tests are all built in plans. Then looking at graphic B in the upper right corner, so less toxicity grade risk with just PD-1 and PD-L1 inhibitors, but you can see some other side effects have been noted with these therapies. So we still have the little blips for rashes and colitis, but then you can see more endocrinopathies. And you can see this dark purple line being a pneumonitis risk. We did not see that with single agent IPI, but we do see that with PD-1 and PD-L1 inhibitors. Followed by way down further into therapy, there is a risk of nephritis from these therapies. In graphic C here in the bottom left corner, ipilimumab plus PD-L1 or PD-1 inhibitors, again, the toxicity grade goes up, unfortunately. And then you kind of are combining both of those timelines. Patients always say, what should I expect, especially when I meet with them on day one and I give them their wallet card with what side effects to watch out for. I say within the first 4 to 6 weeks, I really highlight reporting in rashes and diarrhea. Now, again, can be a little bit confusing, especially for patients that are using these therapies in combination with chemotherapy. But I always say to patients, we would rather know if something's happening than not know that it's happening. Now, let's go through management of immune checkpoint inhibitor toxicity. So many clinical practice guidelines exist. They all kind of have a niche in my mind of when I use it. ASCO has guidelines. They are not updated as often as the CITSI and NCCN guidelines. NCCN guidelines are easier to comb through. CITSI appears to be a little more comprehensive. It has more of the data that you can pull. So for example, I use the CITSI guideline. We've had a few cases of hemolytic anemia from immune checkpoint inhibitors. The CITSI guideline was a better one because it had the resources in there that we could look at. Now, in general, management, grade 1, usually you can continue immunotherapy and you just do close monitoring. Grade 2, hold it. You can consider resuming when it's a grade 1. Corticosteroids may be administered. Grade 3, hold, potentially re-challenge. High-dose steroids are used. We'll talk about that. And then grade 4, that's life-threatening. That's going to be a permanent discontinuation of the immune checkpoint inhibitor, and you're going to see high-dose corticosteroids used. Now, let's do some patient cases. Make sure everyone's drinking their coffee this morning. MJ, 66-year-old female with newly diagnosed metastatic melanoma, presents to clinic for initiation of ipilimumab and nivolumab. Past medical history is listed, very well tolerated, or she's very fit. ECOG performance status is 0. Medications are listed there. She started on IPI and Nivo. Prior to cycle 3, she comes into clinic and she has a rash that developed in the past week with an increasing size, and it is itchy. You estimate it to be about 15 to 20% of her BSA. Does affect the chest, upper chest, abdomen, arms, and upper thighs. We know rashes are the most prevalent immune-related adverse effect. Everybody's implicated in regards to that. A third of patients will have some sort of rash at some point in time. Rashes, again, more often at the beginning of therapy, but I've seen them further down the road. And we do know early recognition and management can reduce the severity of it if you can quickly get on it versus not, and you can keep people on treatment. The grading is listed here. Biggest thing that you're going to look at is the percentage of the BSA that's involved. It's really important to quantify that. Less than 10% is grade 1. Grade 2 is 10 to 30%. Grade 3 is greater than 30%. And then grade 4 is the really severe reactions, potentially full body plus blisters or pustules can happen. Very severe cases. So what grade of dermatologic toxicity is MJ experiencing?
BSA was 50/20, so it's probably B, grade 2.
Grade 2, yes. So here is the management recommendations from NCCN. So with grade 1, you can continue with your immune checkpoint inhibitor. You're going to do moderate potency topical steroids, oral antihistamines. Grade 2, which is what she is, you're going to use medium to high potency topical corticosteroids. If it's unresponsive to topicals, you can consider initiating prednisone at 0.5 mg per kg per day. As you can see with grade 3 to 4, those are higher dose steroids, potentially in higher dose topical steroids. This chart is lovely and amazing because it says the potency of common topical steroids. Hydrocortisone cream is the least potent topical steroid we have. So just know if you have a patient, especially with a grade 2 rash, and you only do hydrocortisone cream, that's likely not going to be enough. So in the guidelines, it says to use a medium to high potency, which are the betamethasone, the fluticasone, and the triamcinolone, which are listed right here in the middle, and they're a certain percentage. Additionally, why I like this chart is it has the vehicle that it's in. So although you might hear the argument that ointments are better than creams, having patients slather an ointment on their skin, which can be very greasy, can be very cumbersome and almost like a level of like more morbidity to them that it's not easy to do, and especially if they're working and staying active versus creams and lotions. Actually, you might have better adherence. Plus, they're actually getting it on and can go about their day. So take that into consideration. So diagnosed with grade 2 ICPI-induced skin rash. We did hold Ipi and Evo for a week. We started supportive care meds. Patient hates steroids. She wanted to avoid those. Perfectly fine. And follow up in 1 week. So which therapy combination, though, for that grade 2 toxicity would you recommend?
Go with D.
Yeah, D is the correct answer. Triamcinolone cream and hydroxyzine as needed for any itching. Awesome. So she comes back. Her rash continued to worsen. She now has more facial edema and erythema. It's now disseminated, about 50% of her BSA, diagnosed with grade 3 induced skin rash. At that point, now that she's failed topical steroids, what would the best treatment option be for her?
Would it be D?
I would lean C. Only reason why, you're definitely going to hold the immunotherapy. The guidelines say IV or PO, but if you're going to admit somebody, I usually say start with IV. You can quickly convert to oral at that time. Okay. Moving into patient case, she was diagnosed from the hospital 1 week later, or no, she presents to clinic 1 week later. She was not in the hospital that long. They did do a very, very slow taper on her because of that severity and the percentage of BSA involved. Again, our oncoderm folks are wonderful. If it's just something that's out of your wheelhouse, I think that's the number one thing guidelines say is to consult that specialist in the area, and I fully endorse that. For her, she continued topical emollients, oral antihistamines. We ended up dropping her ipilimumab and just continuing on nivolumab, and she never did have a recurrence of rash. So good news on that front. Patient case number 2, BG, 50-year-old male with no significant past medical history except PD-L1 positive metastatic gastric cancer. He was treated with IV pembrolizumab every 21 days. Presents to the ED after his 4th treatment, complaining of fatigue, nausea, abdominal pain. Labs revealed the following: ALT 5.5 times upper limit of normal, AST 10 times upper limit of normal. Hepatitis can happen. It's actually pretty frequently. It gets really confusing, especially when in combination with if it's an immune checkpoint inhibitor plus chemo, because some of our chemos cause LFT elevations. But globally, we grade it. So grade 1, ALT, AST less than 3 times upper limit of normal. If you're seeing just that mild bump, consider holding the immunotherapy. Watch the LFT trend. Grade 2, that's when it's 3 to 5 times upper limit of normal. Hold immunotherapy. So even though it's 3 to 5 times upper limit of normal, it is recommended to hold. Monitor LFTs. If they're not budging or increasing, really consider prednisone at that time. Grade 3, which is where our patient landed, hold immunotherapy, initiate prednisone 1 mg per kg per day. Consider hospital admission. Sometimes you can manage these patients as an outpatient, especially if they are, if they're reliant and they'll get their labs like you tell them to. And the guidelines are pretty firm on this, that if it's steroid refractory, if there's no improvement within 1 to 2 days of starting steroids, they recommend adding a steroid-sparing immunosuppressive therapy. Most often one that I've seen is mycophenolate. Infliximab should not be used for hepatitis because it itself can cause hepatotoxicity. Grade 4, which is considered life-threatening, you are going to permanently discontinue that immunotherapy. Other things are very similar. Prednisone 1 to 2 mg per kg. Most often I'll see them start with the 2 mg per kg and then quickly taper if there's a response. So according to the guidelines, which of the following best describes the management of grade 3 ICPI-induced hepatotoxicity? Correct answer for grade 3 is going to be to hold immunotherapy and start steroids. It's not a permanent discontinuation yet. Permanent discontinuation is grade 4. And then, of course, no infliximab. And if you're seeing a grade 3, you should not continue immunotherapy. So for this patient, grade 3, we held immunotherapy, initiated prednisone, and then we monitored LFTs every 1 to 5 days. Roughly for that patient, it was every 3 days, and then we spaced it apart after that, and then taper the prednisone as tolerated over 4 to 6 weeks. Now, I have not touched on this yet, but most tapers need to be slow, so over 4 to 6 weeks. Often what happens if you taper it too fast, you will see a rebound of the side effects. So I would say at least bare minimum for most toxicities, it's going to be a taper over 4 weeks. Even too, I will say in some cases, you could taper it really slowly. And once you hit this, like say you drop by 10 milligrams, sometimes you'll see those levels go back up, for example. And at that point, we go back up to the last steroid dose that the patient had control of that toxicity. So it's usually that previous dose level. Go slow. So patient case number 3, this is a rare situation, but one that I like to highlight. So LH, 32-year-old female diagnosed with triple negative breast cancer. She received the keynote regimen, so carboplatin, Taxol, AC, Pembro, underwent mastectomy, received cycle 12 of Pembro 400 on 8/23 of 2022. That treatment plan, just for those who might not be familiar, you plan to go through 17 cycles. So she did have more Pembro to receive. Beginning in September, so after that cycle 12, she started to call in, and she's only on pembrolizumab. Nausea, abdominal pain, no diarrhea. Started a PPI, H2 blockers, got new scans, right? Triple negative is awful. So we thought maybe it was that. That did not improve things whatsoever. So she was on that for about 3 weeks. At that point, GI consult, colonoscopy was negative, stool testing negative, H. pylori negative. They did a follow-up with her, added on some sucralfate, PPI, Sofran scheduled. It just was not working. She actually presented, it was right around Thanksgiving. I so remember this. Presented to ED, nausea, vomiting, inability to eat. They got her additional fluids, some antiemetics, and she was discharged with a planned EGD. So EGD was consistent with autoimmune gastritis. Patient had continued nausea, vomiting, inability to tolerate orals, had an 11-kilo weight loss. And based on that information, again, autoimmune gastritis is extremely rare. Which of the answers would be the best recommendation for the patient? I'm going to highlight inability to tolerate orals. Hopefully that includes.
Would you just do D, like emitter and give her high dose?
Yeah. Yep. So admit that would probably be best. Again, methylprednisolone 2 mg per kg daily, highest dose, but I think based on her severity, the weight loss, I would do 2 mg per kg and then taper from that. So she was admitted, started on IV methylpred, all the supportive care meds, quickly transitioned to 1 mg per kg due to rapid improvement in symptoms, discharged on 60 milligrams of pred daily, required a slow taper. We attempted to do 10 mg per kg weekly, but then it turned into 5 mg per kg weekly because we got to a point where I think it was at like 30 where the symptoms flared up again. So then we went even slower. We did have to taper by 1 milligram at one point. Final steroids were actually in April of 2023. Super, super long steroid taper, but it worked. We permanently discontinued pembrolizumab. She does remain no evidence of disease, which is amazing, especially for everything she went through and with triple negative. But this really highlighted to me, again, that mentality of immune checkpoint inhibitors. They're so well tolerated. And yeah, we know upfront some of the side effects, but she was on cycle 12, which is about 7 or 8 months in, and she's having these very non-specific symptoms. And so my highlight and something for me that I took away from this is don't shut down those side effects. Really listen and get that good history because something could be happening from that immune checkpoint inhibitor. So this are rare side effects, again, non-specific symptoms. There are case reports of gastritis. There's a brief mention in SITC guidelines where just treat like colitis, which is what we did. And she did require a very long steroid course, but thankfully no evidence of disease to this date. So my final thoughts, there's a lot surrounding immune checkpoint inhibitors and what to watch out for and things to consider. There's the debate when we use dexamethasone for anti-nausea in chemo and immunotherapy plans. Just know there's no rule that says that we can't use that dexamethasone. It's not going to reduce the efficacy. In some studies, like in breast cancer, we used steroids and there was no difference in outcomes. Others, some of the lung data, they excluded it. It's really a toss-up. NCCN, CIMV guidelines talk about that. A lot of studies, though, did exclude patients from using immunotherapy if they're on prednisone 20 milligrams or above. That's kind of the threshold that we think about. So just know that if you're ever looking at a patient. Drug, supplement, herbal interactions, these are fun. There's not a lot of data. Do PPIs reduce efficacy? Do antibiotics reduce efficacy? It's all up in the air. I think you're going to see more flushed out. Even less more is known with supplements and herbals, and especially with mushrooms. We get a lot of questions in clinic from patients. Can I start, whatever mushroom with my immunotherapy? And I go, I don't know. It hasn't been studied. I don't know what it's doing to your immune environment. Again, I touched on this. It's really challenging when immunotherapy is combined with chemos because the toxicity profiles can be very similar, and it's like, ooh. So always feel free to talk to your pharmacist, your other colleagues, to see if they've seen something. Additionally, I talked about all the different immunotherapies that are out there, and I just want to say that some docs have specific preferences for which ones they like to use and which one might not be built, for example. So just know that you might not be able to find all because that disease state might have specific recommendations that they approve. So with that was a lot of information, but I'm happy to entertain questions.
I had a question about, so in the scenario when a patient has like a grade 3 immune mediated toxicity, they're treated with steroids or, holding the drug and monitoring, and then the decision is made to restart the immunotherapy. Is there anything that can be done to minimize the recurrent toxicity? Like for example, the immune mediated hepatitis, if you give them steroids, it goes away. It just seems like if you restart it, my thought is that the chances of having the same reaction
happen again.
Yeah.
I've seen both ways happen in practice. It's a risk versus benefit of that patient getting immune checkpoint inhibitor. I can think of an esophageal cancer patient that had both hepatitis and nephritis. We pivoted, got him on steroids, did something else, but we did re-challenge. We grabbed labs kind of at the midpoint just to make sure things didn't skyrocket. And then they tolerated it perfectly fine. And we have not had recurrence of it. It's so bizarre because, again, you would think it would happen again, but it doesn't happen in those circumstances. I do encourage reaching out to that specialist, like reaching out to a hepatologist to gain their insight, like especially a grade 3 toxicity, like risk versus benefit. What are your thoughts? If they have any recommendations for monitoring and so forth. Good question.
I have a quick question about the endocrinopathy toxicities. So I know that for most of them, we usually just continue like the drug and like treat through the endocrinopathy. Is hypophysitis like the only one where you might like consider holding?
Yes.
Okay.
Just to get it further worked up. Yes. Otherwise, you'll see the, I was going to say liver function test, that's not, but you'll see the TSH and free T4 in plans built. And so usually you can start to see it over time if it's going to change. That's, you need to just give replacement, but you can continue. Unless, of course, if the patient is super symptomatic, but they're usually not. It's usually we see things on labs prior to them actually feeling symptoms. The one thing, too, I'll say about endocrinopathies, some patients, once we burn out that thyroid's gone and patients are on lifelong levothyroxine. So just make sure patients know that because sometimes they will stop it. Anyways, so just make sure that they know that's going to be lifelong.
With specialists have been, super helpful for a lot of this management. Does the Cancer Center have a curated list of the go-to specialists? I know a lot of them have kind of created this as a subspecialty of their practice, like Megan Lutz and GI and Steve Urine cards. I was just curious if there's a resource for that.
No, there's not. And it's something that I think about every single time of like, oh, do we have a phone a friend in endocrine? Who's our phone a friend in hepatology? We don't. I think it's whatever the physician is most comfortable reaching out to. I know like GI toxicities, we're up for this debate with infliximab use, especially clinical trials. If there's a toxicity and if they're not responding within 1 to 2, we're actually jumping to infliximab faster. And so now we're reaching out to GI. How do we get patients infliximab faster? Is it something we can do 1 dose, send it to you guys, but then not all the GI people are aware. And so one of my oncologists will get a hold of a GI person who's like, I don't manage that. And so it's all over the board. It should be more streamlined, but it's all over the board.
But it sounds like a good QI project for the.
No, I am
Cheers.
working on it.
Oh,
But it's
okay.
like political, you know?